Yes, three, two, one.
So, good morning, everybody. Good morning, everyone. Welcome to the teaching class of Department of Urology, SMS Medical College, Jaipur. In the series of interdepartmental meetings, which we recently started, today we have an interdepartmental meeting on uropathology. And the speaker today is a senior professor in SMS Medical College, Dr. Dilip Ramrekhani. And I will just introduce Dr. Dilip Ramrekhani in just a few words. He is a very academic person in our college. He is the senior professor in histopathology. He's also the chief of gastrointestinal, hepatic, and pancreatobiliary pathology in SMS Medical College and Hospital. He has been the organizing secretary of APCON 2016. He is presently the secretary of Rajasthan chapter of Indian Association of Pathology, and he is also a member of the editorial board of Indian Journal of Pathology and Microbiology. So welcome, Dr. Dilip. We are really honored to have you today in our teaching class. And Dr. Dilip would speak today on his basic speech would be on Gleason grading of carcinoma prostate. And I have also requested him to give a little bit of the basis of how the tissue which we usually give after surgery is sampled and processed, and then histopathology slides are made, which will help our residents to know exactly how this is being done. And secondly, I would also request him to give a few slides, which are usually given in the examination of MCH, the basic few slides and how to identify these slides. So thank you, Dr. Ramrekhani. And I would request now you to please share your presentation.
Yeah, first of all, at the outset, thank you, Dr. Priyadarshi, for inviting me, and thank for such kind introduction. And I'll share my content right now. So first of all, I'll discuss about the basic histology process, as we had discussion with Dr. Priyadarshi. He said, first, let us take about the basic histology process. As first, when we send you biopsies or gross specimens to pathology department, what happens to the specimen or the biopsy? So our residents should have an idea of how this goes about and is processed, and finally takes the shape of a slide, which is examined by a pathologist and is given a diagnostic shape, and we get a diagnostic report. So I'll just go through a small video, which will help you guide through the process that what actually happens in a histopathology lab. So I have a small video which we'll go through.
Tissue receiving. Tissue specimens received in the surgical pathology laboratory contains specimen details and patient information. The samples are received fresh or in liquid preservatives such as formalin. Grossing. Grossing is the process in which pathology specimens are examined and trimmed to proper size, and best part is selected for further microscopic examination to obtain diagnostic information. The tissue is now placed in small plastic cassettes that hold the tissue in, and allow fluids pass through the slits to bathe the tissue. Tissue fixation and processing. An essential part of all histological and cytological techniques is preservation of cells and tissues as they naturally occur. Hence the objective of tissue processing is to stabilize the tissues or cells and preserve their morphological, anatomical and biochemical characteristics for accurate diagnosis. To accomplish this, tissue blocks, Sections or smears are usually immersed in a fixative solutions. Most commonly used fixative is 10% neutral buffered formalin. Dehydration. Water is present in tissues in free and bound forms. Tissues are processed to the embedding medium by removing the free water. To minimize tissue distortion or shrinkage from dehydrant, delicate specimens are dehydrated in a graded ethanol series from water through 10%, 20%, 50%, 95%, 100% ethanol. Clearing. Since alcohol and paraffin are not miscible, alcohol must be replaced with an organic solvent that is miscible with both alcohol and paraffin. The tissues are usually put through 3 changes of the clearing agent and transferred to paraffin. Paraffin embedding. Tissues from the processor are in molten paraffin and are still in the cassettes, then transferred manually into the embedding molds. Tissues must be aligned properly at the bottom of mold, and the bottom part of the cassette containing accession number need to place over the mold. The mold and cassette are then filled with more molten wax. The paraffin is then allowed to solidify by putting the embedding molds on a refrigerated surface. Once the paraffin is solid, the entire block with the cassette is popped out of the mold, and the block is ready for thin sectioning using microtome. Section cutting or sectioning. Once the paraffin has solidified, the tissue block is removed from the mold and placed on microtome. In microtome, due to friction between the knife and paraffin block, enough heat is generated with the cutting action, allows the tissue section to adhere with each new section and forms a ribbon of sections. The ribbon is floated on warm water bath to remove any compression and wrinkles in the tissue caused by the cutting action, and the desired section is picked up on glass slide.
So this is how the tissue gets stuck using the paraffin wax onto the slide, and then it is stained using the hematoxyl and niacin stain. And then the slide is brought to us and we examine it under the microscope and for the details. For IHC, it's a separate process, and I think this is beyond the purview of this probably lecture. So basic histopathology this is the process for basic histology.
Thank you, Dr. Dilip. It was really
Now, uropathology. Yeah. So now we move on to basic uropathology, and we touch upon the basic slides in uropathology. And first, we'll cover tumors of the kidney. As you all know, the most important and most common and important malignant renal tumor in adults is renal cell carcinoma. Now, there are several subtypes of renal cell carcinoma. If we start talking about renal tumors, it's an entire lecture in itself, but we'll touch just upon renal cell carcinoma. And even renal cell carcinoma itself is a lecture in itself, but there are several subtypes which are classified on the basis of histology and now on the basis of IHC molecular subtypes. Now there are in fact 25 subtypes of renal cell carcinoma, not just based on histology, but on the basis of molecular subtyping. So we'll not go into much details, but I'll just give you a broad overview of the various common histological subtypes of renal cell carcinoma. So it's the most common primary malignant tumor of the kidney, which is derived from renal tubular epithelium. And as you all know, as clinicians, leading urologists, that the classic triad is of presentation of a patient as a hematuria, flank pain, palpable mass. And they are usually detected with any of these three triad, or they are detected on imaging for some other reason. They get picked up. Renal cell carcinoma may be part of a hereditary syndrome like von Hippel-Lindau, which is associated with cerebellar and retinal hemangioblastomas. More often than not, they are usually sporadic tumors. So if we see that coming to the histologic types of renal cell carcinoma, the common histologic types that we encounter is, okay, let's see. So the commonest is the most common and with the worst prognosis is clear cell carcinoma. And this clear cell carcinoma is shown in these two slides. This is the low to medium power and this is the high power. I'll show you the cells. You can see they are large and polygonal cells and they have a clear cytoplasm. And why these large and polygonal cells, why they have a clear cytoplasm? This you can appreciate in high power, a large polygonal cell with a clear cytoplasm with a nucleus. And this is a clear cytoplasm because of the accumulation of cytoplasmic glycogen and lipid. And there are areas in which this cytoplasm might be pink and granular also. So they are derived from renal tubular epithelium and this is the commonest type of, hence they call it clear cell carcinoma variant of renal cell carcinoma. And this we have to specifically mention on the reports. Why? Because oncologists wanted the therapy they want to tell us whether it is clear cell versus a non-clear cell. The therapy is still totally different. So oncologists wanted mentioned on the report. The second most common variant is the papillary type. This is the papillary. Here you can see these papillae. They are usually surrounded by a thick fibrous capsule and they have extensive areas of necrosis and hemorrhage. And microscopically, what you see is a papillary structure. So this is a papillary structure. Here you see a fibrovascular core, which is lined by this is the fibrovascular core. And you see the lining of this core. This is composed of these papillary cores are composed of cuboidal to columnar malignant epithelial cells. And these papillary cores contain foamy macrophages. Then we have the third type, which is the chromophobe carcinoma. So this chromophobe carcinoma is composed of sheets of malignant epithelial cells. Now they have a pale cytoplasm. The characteristic of this chromophobe carcinoma is that the cells have pale cytoplasm and you can draw these boundaries of these, you can draw the boundaries of these cells. They have a prominent cell boundaries like plant cells. And they have a very relatively poorer prognosis. And the last category is the collecting duct carcinoma. They are rare, aggressive tumors. They arise in distal collecting ducts of renal medulla. They have infiltrating tubules. They are composed of pleomorphic cells. Here you can see these tumor cells labeled as T infiltrating in between these normal glomeruli labeled as G here. So they are very, very aggressive, and they cause a desmoplastic reaction. That is a fibrous tissue reaction. And now, as I told you, now this morphology classification is long. The earlier things were simpler when we used to simply call it clear cell versus non-clear cell. Then they told us better classified as papillary, chromophobe, or this collecting duct carcinoma. Now there are several morphologic molecular subtypes, not just morphologic, but molecular subtypes of renal cell carcinoma. And some of these molecular subtypes have targeted therapies for them. And for these, you have to resort to advanced molecular techniques for the diagnosis. First, suspect them on histology, and then preserve the tissue for molecular analysis. So things have really got complex. So uropathology, and especially the kidney tumors, have, expanded a lot with each classification. That brings us to now testicular tumors. In testicular tumors, the most common tumors, as you know, are germ cell tumors. And in germ cell tumors, let me tell you something broadly about testicular tumors. That is, excuse me. Testicular tumors in adult males, they are usually mixed germ cell tumors. That is, 2/3 of them are mixed germ cell tumors. Pure germ cell tumors as such just compose 33% or 1/3 of the clinical cases. You compare them with ovarian germ cell tumors in females. In ovarian germ cell tumors, most of them, that is in females, the ovarian germ cell tumors are basically mature teratomas or dermoid cysts. They are benign. But in males, they are usually malignant. The most of the germ cell tumors in males, they are malignant. So in testicular tumors in males, they are divided into two main subtypes. First, we call them seminomas, and the second broad group, we call them non-seminomatous germ cell tumors. So seminoma, so why this classification? So seminomas are malignant cells which resemble the normal cells of lining the seminiferous tubules. You know the normal structure of a seminiferous tubules. In MCH, I don't know whether you still remember your second MBBS testicular slide. I didn't put it, but the cells of seminoma resemble the malignant cells. They resemble the normal cells lining the seminiferous tubules. So that is seminoma. And in non-seminomatous germ cell tumors, they are tumors which exhibit differentiation towards the embryonal or extraembryonal structures. So we'll see when we see the example of each subtype. So this is a classical seminoma. So what is a classical seminoma? It's the most common tumor of the testis. Peak incidence between 30 to 45 years of age. Macroscopically, you all know it's a circumscribed, pale, creamy white, homogeneous tumor, lobular pattern. Necrosis and hemorrhage is rare. It's a malignant tumor. Spread is via lymphatics, spreads to iliac and para-aortic nodes. So histologically, they show this classic appearance, this slide which I have put up. It's a classic seminoma. There are sheets of these uniform polygonal cells, these sheets of uniform polygonal cells you see, they have this clear cytoplasm. They have a round central nucleus. In the center, you can see this round central nucleus, which has a prominent nucleolus. Cells are divided into clusters by these thin fibrous septa, and these thin fibrous septa are infiltrated by these blue dots, which are nothing but lymphocytes or inflammatory cells. Okay. And these small lymphocytes, sometimes this inflammation is so marked or even granulomatous. At times, the distinction between granulomatous orchitis and seminoma is so difficult that sometimes there's an erroneous sign out as granulomatous orchitis, query tubercular, and sometimes this seminoma is missed out. That is what I'm saying is, you see these clusters of clear cells and you see this thin fibrous septa with inflammation, and sometimes this inflammation is so marked as to cause a granulomatous response. And sometimes if you're not suspecting, the history is missing, radiology is missing, and in the periphery, the pathologist might be tempted to sign it out as a granulomatous orchitis, query tubercular, especially if sometimes there is a miscommunication that there was a gray-white appearance on grossing. So he might think that it was probably a caseous necrosis and you are seeing a granulomatous appearance on microscopically. So sometimes these tumors might be missed for probably a tubercular orchitis or something. So next in the category is a teratoma. So in adults, these testicular teratomas, they are composed of both mature and immature tissues. And what are those immature tissues? These immature tissues are nothing but fetal type tissues, such as this cartilage, which is labeled as C here. So these are cartilaginous tissues. These are fetal type of cartilage. These are the immature tissues. There is this mesenchyme M. These are the small epithelial glandular structures, which you see here. So these are those. This is a mixture of mature as well as immature tissues, and they behave in a malignant fashion. Contrast it with ovarian teratomas, which are always benign. Sometimes you cannot see differentiation between these mature and immature tissues, and they are frankly carcinomas. So sometimes you can't see this distinction. They appear frankly like a carcinoma or a sarcoma. Next, we move on to embryonal carcinoma. So this is a classic slide of an embryonal carcinoma. These tumors occur in younger men comparatively, 20 to 30-year-old. They are more aggressive as compared to other testicular tumors like seminomas. They can present in more pure form, but mostly these embryonal carcinomas occur in mixed forms. That is a component of the mixed germ cell tumors. Grossly, they are poorly circumscribed. You see areas of hemorrhage and necrosis. And low power, if you see, this is a median power image. Even in low power, it looks like a carcinoma. That means if you put the slide under microscope, it will be a large anaplastic tumor with these gland-like. It will look like a slide. If somebody never told you that's a slide from a testicular tumor, you will probably sign it off as an epithelial malignancy or a carcinoma. You see these kind of tubular, glandular, papillary structures, which look like a typical epithelial malignancy or a carcinoma. So these T stands for tubular structures, G are the glandular structures. So this malignant, frequent mitotic figures, not appreciated at this, but under high power for a pathologist. So this looks like an epithelial malignancy under the microscope. Vascular and lymphatic invasion are common in this tumors. It infiltrates beyond the testis into adjacent structures such as epididymis. So this is a highly malignant tumor. Next, we come on to yolk sac tumor, also termed as endodermal sinus tumor. Again, this pure yolk sac tumor is again rare in adult men, occurs as a component of mixed germ cell tumor. This affects even younger age group, male infants, young boys. It resembles yolk sac of developing embryo. So wide range of histological patterns. Common is this microcystic or lace-like pattern. And the characteristic common feature to identify this under microscope is this Schiller-Duval body. What is this Schiller-Duval body? This looks like a primitive glomerulus. This labeled as D is this Schiller-Duval body. Again, a Schiller-Duval body. This looks like a primitive glomerulus or a fetal glomerulus. If you see this you are dealing with a yolk sac tumor. And for a clinician, if you get the AFP levels done, if the AFP levels are raised, there's a suspicion that probably in a proper clinical setting, for example, a young boy, AFP raised, and you see such fetal glomeruloid structures in the slide, you're probably dealing with a yolk sac tumor. I'll show you a few examples of mixed germ cell tumors. For example, this is an embryonal carcinoma. Again, looks like an epithelial malignancy. And here you see these cartilaginous structures. Okay, so this is cartilaginous structure. This is embryonal or epithelial malignancy-like structure. So this is a mixed testicular germ tumor, that is embryonal carcinoma and a teratoma. I'll show you again one more slide of a mixed germ cell tumor. Again, looks like an epithelial malignancy, very, very epithelial looking carcinomatous malignancy mixed with the seminoma. Again, clear cell of a seminoma. So this is embryonal carcinoma And this is seminoma, again, typical germ cell tumor. So as I told you, 2/3 cases of clinically of testicular tumors are in fact mixed germ cell tumors. Only 1/3 of them are pure germ cell tumors. So whenever you send a requisition form to the pathology department, always get this AFP levels, beta HCG, and LDH levels done and mention them on the form. It helps us also. Sometimes what happens in grossing, you see a seminoma and we are about to sign it out. Then we always ask a resident, what about the tumor markers? So many times it happens that we ask a resident and the resident says, sir, the AFP levels and probably the HCG levels are raised. And the slides show typical seminoma. So we tell the resident to please give more sections from the gross. It doesn't look like a pure seminoma. Although it looks like a pure seminoma on microscopy, probably we are missing the mixed germ cell tumor component, because clinically these levels indicate that there is some hidden component. There is some component which is secreting these tumor markers, and there must be an element, because I told you 67% of these tumors are in fact mixed germ cell tumors. So by meticulous grossing and by your clinical feedback on these tumor markers, we are able to diagnose mixed germ cell tumors, and it does affect the subsequent management of these patients. Let us move on now to disorders of the prostate. The commonest specimen we get from you is BPH, that is benign nodular hyperplasia or hypertrophy, which affects men from middle age onwards, probably related to altered hormonal balance. Obstruction to bladder outflow due to pressure on prostatic or urethra results, and this might result in hydroureter, hydronephrosis, pressure atrophy of renal parenchyma, predisposing to infection and stone formation. So as we already know, BPH is a common condition affecting middle-aged to elderly men. It affects basically the transitional and the periurethral components of the prostate gland, which undergo glandular hyperplasia as well as hypertrophy of the fibromuscular stroma of the gland. An important thing to distinguish between BPH and prostate carcinoma is that the peripheral zone of prostate is not involved in the hyperphagocytic process. In fact, it becomes compressed and atrophic at the outer margin. Let's see it in the slide. Okay. So this is the slide of benign prostatic hyperplasia. So this is the low magnification and this is the high magnification. At low magnification, you see the rounded nodules of hyperplastic prostatic tissue, and this is the transitional paraurethral part of the gland, and you see these rounded nodules of hyperplastic prostatic tissue. These are the glands, this is the stroma, and this is the hyperpus. This is the high power. In high power, you see these acinar glands, you can see this basal layer, and you can see this hyperplastic stroma. And you can see this compressed peripheral zone indicated by N. Okay, so this does not participate in the process, and this is compressed at the periphery. And you can see this corpora amylaceae at the periphery. So what happens in benign prostatic hyperplasia is the periurethral portion or the transitional portion which is involved causes compression of the urethral lumen, leading to this clinical symptoms like hesitancy, urinary stream, urinary retention. So again, macroscopically, grossly, the prostate has a nodular microcystic appearance, tiny cysts, and you see dilated hyperplastic prostatic glandular acini, which contain often small laminated concretions, which are known as corpora amylaceae. You can see them microscopically also. These are these corpora amylaceae. So the moment we see corpora amylaceae in these biopsies, we are sure we are dealing with a BPH. So important thing is that, excuse me, that in high power, we see these tall columnar epithelial cells, which are lining these glands. And these are thrown into papillary folds. And important thing is that they have a basal lining. And this fibromuscular connective tissue is also there. This fibromuscular connective tissue also undergoes hyperplasia. And sometimes this might be accompanied by an element of chronic non-specific prostatitis, or sometimes there must be overwhelming chronic prostatitis also. Let us now move on to prostatic carcinoma, which I thought would be a significant part of this lecture, but I think combining everything, we wanted to cover basic uropathology in 1 hour. So every component had to be covered. So let's now talk about prostatic carcinoma. So invasive carcinoma of prostate is common, important malignant tumor, starts from prostatic intraepithelial neoplasia. So there is staging. Staging is more clinical. You want to know the degree of spread within the tumor, extension beyond the prostate into lymph node, distant metastasis, perineural and vascular invasion. So clinically you want to see, and there is obviously you have imaging modality. So that is staging. I'll not discuss. It is more of a clinical and a radiological issue. But I'll be more concerned with adenocarcinoma of the prostate and its grading. So this is Gleason originally described the grading of prostatic carcinoma. The famous cartoon which Gleason made has got modified over time, and there have been several controversies. There are several meetings like ISUP, WHO, several modifications, and those need not go into controversy. Leave it to uropathologists. But for basic uropathology, I think it's suffice to say that this cartoon is a basic figure on every uropathologist table while reporting. So this is grade 1. So you can see glands close together. Grade 2, there is some amount of distortion which is coming. Grade 3, you can see this. There's some distortion, and you see this angulation of glands, some amount of glands again getting smaller and smaller. Grade 4. In grade 4, there is some small cell change, cribriforming taking place, glands getting angulated, irregular. And in grade 5, there are very, very pleomorphic, irregular glands, small cell change, totally loss of glandular pattern. So grade 1, grade 2, grade 3, grade 4, grade 5. Okay, so this is the basic figure which was made by Gleason, but has got subsequently modified over the years. Okay, so a few words about scoring. So we basically score these patterns. So whenever you look into the biopsy or the core submitted by you, so we see what is the predominant pattern. Okay, so that predominant pattern is first of all given this score that comes first. For example, if the predominant pattern is score 3, we give it Gleason score 3. And then we look at the minor component. Suppose it is score 4, it will be given Gleason score 4. Then we add the two. So Gleason grade 3, suppose it's the predominant pattern, will be given first, the primary grade, grade 3. Secondary is the less predominant pattern, grade 4. We add the two to arrive at a Gleason score. For example, it is Gleason score 3 plus 4 equal to 7. Then this is given a grade group. Now you might say this, both of these are Gleason score 7, but the grade group is different. So here, although the score is the same, so this grade grouping was introduced in WHO classification or WHO grading of prostatic tumors 2016, and is still in vogue. There's not been modified as yet. So this determines the clinical prognosis of prostatic tumors, whether you want to observe, whether you want to intervene, whether you want to operate, whether you want to give them radiotherapy or not. So for example, let's see. This is also Gleason score 7. This is also Gleason score 7. But here the predominant or the primary pattern was 3. Here the primary pattern is 4. So obviously this is a clinically grade group 3. This has a worse prognosis compared to this, because here the primary pattern was a lower pattern, grade 3. Here the primary pattern was grade 4, which was a higher pattern. So obviously this falls in a higher grade group. So with this background, let us examine these prostatic cores. So this will tell you, this is an example of a Gleason grade 3 carcinoma. So how do you find it's a Gleason grade 3 carcinoma? You see small round malignant glands. These are small round malignant glands. Now you'll ask me, sir, how will you see that? What makes you think that these are malignant glands compared to benign prostatic glands? So see here, these are these benign prostatic glands. These are the benign prostatic glands. Can you see the difference? These benign prostatic glands are, in fact, you can see that they have this basal epithelial layer. You can see that their nuclei are smaller. They are not as hyperchromatic. You can see these papillary infoldings. They are larger. And here you see these small glands which are round, They are close together. They have a hyperchromatic nuclei, means more blue nuclei. There is no basal lining. There is no basal epithelial layer. They are coming close together. And you can see this. They typically appear malignant to the eye of a pathologist because they are closer together. Their nuclei are hyperchromatic. The nuclear cytoplasmic ratio is more. That means the volume occupied by the nucleus within the cell is larger. So these malignant cells, which are grade 3, that is of the lowest grade. If you go to this is the grade 3. These are occupying this and they are infiltrating between these normal appearing prostatic glands. Compared this to grade 5. What is grade 5? This is grade 5. I am telling you this portion of this grade 5. I'm showing you this extreme and I'm showing you this extreme. And the rest all lie between this. So I'm showing you this grade of gray and this shade of black. All this lie between these shades of gray and black. So this is, I've taken these two extremes. So this is grade 5. And this grade 5 is this. These malignant cells are forming sheets of pleomorphic cells. No glands, only sheets of pleomorphic cells which are invading the stroma. So this is grade 5 prostatic carcinoma. Okay. And you see various combinations. For example, if this was the prominent pattern, this was the less prominent pattern in a biopsy, this will be 3 plus 5. Let's see where it will fit. This will fit somewhere here. 3 plus 5. Okay. 3 plus 5 would be here. This will be labeled as, the report will read something like this: prostatic adenocarcinoma, grade group 4, Gleason score 3 plus 5 equal to 8. Okay, so this will be a sample report, something like this. Let us now move on to the last portion of my talk, which is disorders of the penis. So in disorders of the penis, I have selected the commonest tumor of the penis, that is squamous cell carcinoma. So here's the slide. Excuse me. This slide shows a well-differentiated keratinizing squamous cell carcinoma. Here you can see the keratin pearls, and these are islands of tumor cells extending deeply into the stroma. This island, this island. So if it was only this, you could probably mistake it for pseudoglandular. Many times you have seen report from a department. Suppose it was only this, you would probably mistake it. Suppose it was a superficial biopsy and it was only this portion. The report from a department would, or from other center would most likely would have been pseudoepitheliomatous hyperplasia. So we need, in fact, to see these islands of tumor cells separating and, in fact, deeply penetrating separately into the stroma to call it, in fact, a squamous cell carcinoma. Okay, so you need to see islands of tumor cell extending separately and deeply into the stroma to call it squamous cell carcinoma. And why I have called it a well-differentiated keratinizing? Because I am seeing these keratin pearls into this. So squamous cell carcinoma of the penis is now classified into 2 types: HPV-related, non-HPV-related. Now this classification is similar to tumors of the vulva and the perianal region. So by looking at the microscope, can you say whether it is HPV-related or non-HPV-related? Yes, a pathologist can get an idea, because HPV-related squamous cell carcinomas, grossly a clinician also can get an idea, because HPV-related squamous cell carcinoma of the penis are more warty in appearance. And if a pathologist looks into the slide, he sees a basiloid appearance. That means these cells appear more blue. They are not these pinkish in appearance. They appear more blue. We call it basiloid. So we suspect that they are HPV related, and now there is surrogate HPV marker which we call as P16. We do IHC on this. If they are P16 positive, we call it HPV related squamous cell carcinoma. And if then there is a second non-HPV related tumors, now there are several morphologic subtypes for it. We have verrucous carcinoma, sarcomatoid carcinoma, spindle cell squamous cell carcinoma. So these are the various histologic subtypes of non-HPV related tumors. So this brings me nearly to the end of my talk, and let me introduce to this god of uropathology. This is Dr. Mehul Amin. He is in fact responsible for the AJCC 8th edition 2017. He's a KEM graduate, and he's in USA, and he's given us this AJCC 8th edition, which is revolutionizing, in fact, this tumor staging all over the world. He's a pathologist, and he is in fact respected by all clinicians all over the world. This guy is Santosh Menon, a uropathologist at Tata Memorial. This is me, and the occasion is World Cancer Congress several years ago at New Delhi. And thank you all for your patience, and I'll be glad to take any questions if there are any.
Thank you. Thank you, Dr. Dilip. Can you hear me? Yes.
Yeah, sure.
Actually, I had a little bit of unstable internet, so it's a problem. I will just. Can you hear me now? Yes.
Your voice seems to be echoing, sir.
Okay, I will just put my this off.
Meanwhile, sir, can I ask Dr. Dilip some questions?
Yeah, sure. Please go ahead.
So first of all, compliments to you for an excellent lecture, and within a short period of time, you managed to cover all the aspects. And
yeah, I tried whatever I could.
So we could gather most of the content of the talk. In the section on testicular tumor histopathology, you showed a slide whereby both the seminomatous and the non-seminomatous tumor was, in a single slide. So how common do you find seminomas and non-seminomas in a single specimen?
Yes, I mean, it is quite common.
That we don't see very commonly. Either we see seminomas or we see non-seminomas in a mixed variety, but never the two in combination. So that was my question.
It occurs in mixed germ cell tumors. It is not uncommon, I would say.
Yes, I think yes. Purely seminoma is not very common. You usually get a little bit of non-seminomatous element also in seminomatous tumors. Yes. So yeah. So that is.
So as I told.
Yeah.
I told 2/3 of them are mixed germ cell tumors. So you get a component of seminoma. I agree, like seminomatous components do occur with. I have seen cases where seminoma does occur with other germ cell tumors. I've seen cases not very rare also.
Right. So very well presented, Dr. Dilip. Thank you very much. And but definitely the Gleason grading, you could have done it in a more elaborate manner. I understand.
Yeah, I could. It will take one more class, sir.
Right. I understand. But I would just try to, for the benefit of our residents, would just like to tell them that this Gleason grading, as Dr. Dilip has already said, started by Dr. Donald F. Gleason in around 1960s and 70s, when a Veteran Administration of United States had a very large randomized controlled prospective study in around 2,900 patients. And they noted down all the histopathology pictures of all these carcinoma prostate and brought out this Gleason grading. And then again, there is a long history of Gleason grading. There were a lot of modifications. And then the ISO 2005 and then 2014 just changed a lot of things, like the grade 1 or 2 was totally almost obsolete. And then less than 5 was almost probably, now we start with 6 rather than have any.
So 3 is the minimum. 3 is the minimum grade you.
Right. So 3 is minimum and the score minimum is 6. That's what I'm saying.
6. Yes.
So and still and now there is a suggestion that even 3+3 is probably not malignant, and
So 3 and +3 they usually observe. Observe the patient.
That's right. Another one thing that needs to be seen is about the tertiary pattern in these patients. Like we know about the primary and secondary patient. That we know in the ISO 2005, And then after 2014, they said if there is a tertiary pattern, then probably the tertiary pattern should be taken rather than the secondary pattern as the score. So again, that is again one of the very important things probably they said. And then there was things like ductal adenocarcinoma, colloid adenocarcinoma. What should the score be in these carcinomas if they are different from the usual carcinoma? So if you want to just make a little statement or a brief comment on these modifications, you are most invited. Most welcome.
So no, I would have taken a separate class. Actually, I would beg your pardon on this issue because I didn't go into the intricacies and controversies. Why? Because
I understand.
This
was only because of my suggestion.
Yes. There are two issues because I was standing for President IAPM. Yesterday, my election concluded.
Okay.
So and second, I don't practice uropathology these days. I just do basic GI pathology. So I would have actually, in fact, would like to have gone through all these latest literature before preparing a class on this controversies and all. It has actually, there is now new evidence which has come up, which examines all these controversies on prostate grade. In fact, Gleason's grading recently. So I would have actually didn't get much time to prepare this this part actually. So this would probably take some time, and probably next time maybe I would so I just covered most of the basic aspects of uropathology as outlined by you. So I would, in fact, take my sincere apologies for this. So I could just cover all the basic aspects of uropathology in this lecture. So actually, in fact, I started preparing late evening, and I didn't want to miss this class because I had given a commitment to you.
I think there is some network issue, sir, with Dr. Shivam's connection.
Yeah.
He seems to have logged off.
So Gleason
any
grading,
of the residents who are
any
class,
questions, most welcome.
Please put forward your questions to
Dr.
Sure,
please.
This is a very good opportunity for you to clear your doubts.
Yeah, most welcome to ask any questions. Yeah, am I audible to all the residents?
Yes, sir. You are audible.
So,
or they can put it in the chat box or something. I mean, or they can, I mean, I don't see anybody like putting up any questions.
So one of the common questions, if I can ask on behalf of the residents, and this question is asked in their examination almost consistently.
Yes,
this is in relation to carcinoma of the penis.
Yes.
And the usual question that is put to them is that you should always have a normal, a wedge biopsy of the penis is mandatory. And it should include a normal tissue of the glands or, some of the normal area of the penis in order to, better quantify or better, describe the architecture of the histopathology. So why do you think a normal area of the penis needs to be included in the biopsy?
Exactly. So yes, exactly. So I was basically coming to that only. So as I told you earlier, many times it is difficult to find areas of invasion and all. So if you see I have a normal area and you have a representative malignant area, so it helps us to differentiate between pseudoepitheliomatous hyperplasia versus an invasive focus of malignancy. So, I mean, it helps us differentiate whether these are reactive changes versus a frankly invasive malignant change. So it helps us, in fact, come to a very, very conclusive diagnosis. I hope I have answered your question.
Sir, you are muted, sir. Shivam, sir.
Okay, fine.
And one more question is, a few of the biopsies I'm receiving, I think, I don't know whether it's a thesis, MCH thesis or from Euro 3 department is, many times I'm receiving biopsies from several different sites, the prostatic cores, the PSA levels are around 59, 60, and but I don't seem to find any malignancy in any of the cores. So is it possible digital rectally hard nodular prostate, PIRADS 5, but hardly any malignancy in any of the cores, especially one suspicious core? Is it possible clinically?
Yes, Dr. Dilip. We come across many of these patients who have prostatitis or acute prostatitis with PSA even more than 100 or even going in maybe hundreds. So that is possible definitely. But yes, because not all of these patients are hard nodular, and many of these will have only raised PSA without any nodular prostate. But again, we have to go.
But PIRADS 5, I mean, every report has PIRADS 5. I mean, I'm getting a regular flow of biopsies. We are getting a regular flow of biopsies from your unit. Is it the thesis topic or something? That's what I'm.
No. We actually have started doing trust guided biopsy in our own department.
Okay.
So this every patient is getting trust guided biopsy. We send you 12 core biopsy of all these patients, who have raised PSA. So many of these patients who have raised PSA may not have malignancy. Again, MRI, most of these patients, we get the MRI also done because the radiology people have kind of thesis probably, or they are doing some work on correlation between PSA and MRI. And that is why you are getting MRI also every patient. Maybe, I think, but again, we will look into it, whether how many patients of PIRAD 5 are actually being benign. And that would be a very interesting thing to note, because it seems very improbable that PIRAD 5 would always look like a benign. So anyway, thank you, Dr. Dilip. And thanks all the viewers for joining us today in our uropathology class. Thank you and have a good day. Thank you once again.
Thank you, sir.
Thank you very much.